Hi, my name is Rosana Navarrete Verduga. I'm a student at Catholic University. I am going to talk to you about Niraparib in patients with newly diagnosed advanced ovarian cancer. Definition: Niraparib, an inhibitor of poly-ADP reverse polymerase, has been associated with significantly increased progression-free survival among patients with recurrent ovarian cancer after platinum-based chemotherapy, regardless of the presence of advance of BRCA mutations. The efficacy of nirparib in patients with newly diagnosed advanced ovarian cancer after a response to first-line platinum-based chemotherapy is unknown.
Number 9. PARP inhibitors for maintenance therapy in ovarian cancer.
The diagnosis is never easy to hear. It is a battle within the body. With ovarian cancer, cells in the ovaries grow very rapidly, creating damage to DNA. There is an enzyme designed to fix this damage, poly-ADP ribose polymerase, better known as PARP. But fixing the DNA allows the cancer to grow. Using a PARP inhibitor blocks the enzyme from repairing the damage in cancer cells, representing its usefulness in cancer treatment. In 2018, the FDA approved the first PARP inhibitor as a maintenance therapy after a first line of chemotherapy in women with BRCA gene mutations. Until now, maintenance therapy, the use of a therapy to prevent or delay cancer's return after achieved remission, hasn't been widely explored in cancer of the ovaries. Results from a study released earlier this year showed a 70% reduction in the risk of recurrence at 3 years in the group utilizing the approved PARP inhibitor. Researchers hope that PARP inhibitor use will show improved long-term outcomes, arming women for the fight against ovarian cancer.
Applications in medicine. Niraparib is used to help maintain the response of certain types of ovarian, fallopian tubes, and peritoneal cancer in people who have fully or partially response to other chemotherapy drugs. It is also used to treat these types of cancer when the cancer has gotten worse after 3 or more chemotherapy treatments. It works by killing cancer cells.
Niraparib was actually approved in the maintenance setting. It's the one unique PARP inhibitor that doesn't have the treatment indication yet. This should follow platinum, actually 2 prior platinum therapies. The Niraparib also was approved without any indication for molecular testing, so we don't need to know the BRCA status for these patients. So what we've learned from these trials is there are manageable toxicities with niraparib. We know that platelet toxicity is one that's probably most notable, and certainly as a clinician we need to be on our toes for this, that we should be monitoring our patients closely and doing weekly labs for the first month, and then anytime we make dose adjustments, we should be doing weekly laboratory studies with the CBC monitoring platelets. And we've actually identified a population of patients that are thinner and coming into the starting therapy with a lower platelet count. So I believe if their weight's less than 77 kilos or their platelet count's less than 150,000, we want to think about probably starting those patients on 200 milligrams per day rather than the normal 300 milligram starting dose. The PRIMA trial is their upfront trial looking at standard chemotherapy followed by niraparib, and this is a randomized trial. Again, we hope to have those results out in early 2019. Quadra is a trial with niraparib really designed to have niraparib end up with the same type label indication as the other two PARP inhibitors. So this is in patients that we have in a treatment type setting, and the preliminary results, or at least that have been released publicly, show this to be very active in patients with both BRCA mutated status, wild type, platinum resistant, platinum refractory. We see actually quite nice response rates in that population. I believe we'll see another formal presentation of this at ASCO here 2018. The other trial I would like to mention is Topazio, which is a combination of niraparib plus a PD-1 inhibitor. This was presented at the SGO 2018. I think there'll be an update at ASCO 2018 showing a very nice response rate and disease control with a combination of an immunotherapy agent and niraparib.
Pros and cons. Pros. Effective treatment in studies carried out. It has good results regarding the survival of patients. Cons. It can cause side effects and some of them can be serious. It could increase the risk of developing other types of cancer. It could decrease fertility in men.
So this is a trial that started a number of years ago. It's called the NOVA trial, N-O-V-A, and it's examining the PARP inhibitor called niraparib. Niraparib is an oral PARP inhibitor. It's very potent. And the trial design is that women had to have platinum-sensitive recurrent ovarian cancer. And not just that platinum when they sort of were entering into the trial, but the penultimate platinum as well, meaning the second to last. Their cancer had to show responsiveness to the agent platinum. They also had to have a special type of histology called a high-grade serous ovarian cancer. And then also the groups were broken into whether or not women had a germline BRCA mutation, or if their cancer had the test called the homologous recombination deficiency test. Basically a test that would indicate possibly that cancer would be more sensitive to a PARP inhibitor if the tests were positive versus negative, really taking out the germline BRCA, that kind of being a very major driver of PARP inhibitor sensitivity. So it was a 2-to-1 randomization. Several hundred patients were enrolled. The data has now been published in the New England Journal. It was published late 2016, showing an improvement in the median progression-free survival for women who received niraparib versus placebo.
Issue applied in Ecuador. In Ecuador, the risk of developing cancer before the age of 75 is approximately 20% and constitutes a major public health problem with an increased incidence. The Pan American Health Organization is working to strengthen cancer prevention policies, including tobacco control, reducing alcohol consumption, improved quality and access to screening programs, especially to achieve early detection of breast, ovarian and cervical cancer, and improve the quality and access to cancer treatment and palliative care. Conclusion: ovarian cancer patients who respond to platinum-based chemotherapy and receive Niraparib tend to have significantly longer progression-free survival than other treatments, despite how uncomfortable many of these side effects may be and is a very effective treatment.
Right now, we don't have a label we only have label in Europe for patients who are BRCA mute on olaparib. So these patients can receive standard of care olaparib. For the rest, we don't have any label. We have expanded access program in Europe for niraparib, so we can treat our patients with niraparib. Soon we will have niraparib registered, and I hope that all three drugs would be able to be registered, or at least two of them, because there's a phase 3 data on niraparib and rucaparib. So the patients would be able to get one of the PARP inhibitors. Which of the drug I will choose? I think that both the efficacy and the tolerance wise, it's easy to deliver both drugs. So I don't have in that case preference, only my bias, because I'm the PI for the NOVA trial. So it's niraparib what I would like to do. But I think here we have to look at the socioeconomic conditions, and we have to, in Europe at least, where we have to, the taxpayer has to pay taxes for the medicine. So hopefully, and it's great that we will have two drugs, so the governments can bargain the price down, so we can get the cheapest of the two for our patients.